This conference will now be recorded.
Hello, class. Happy Friday afternoon. I wanted to provide a little bit of information regarding the Ramsey Sedation Scale and weaning from the ventilator. This is just going to be a short session, but I'm going to share my screen with you, and I'm going to post an announcement regarding the Ramsey Sedation Scale. And so what the Ramsey Sedation Scale is it's a way that you can objectively look at sedation. So the way that you've got to think about it is it's kind of like a pain scale. So what a pain scale is, a verbal pain scale, is a scale of 0 to 10, with 10 being the worst pain you've experienced. So the purpose of a verbal pain scale is for you to be able to put pain in an objective, measurable way. So pain is very subjective. So you can't really know what someone's pain level is, but them telling you what it is on a scale of 0 to 10 will put pain in a measurable, objective format. So the Ramsey Sedation Scale does the same thing. It's a way that you can more objectively measure a level of sedation. So whenever a physician orders a Ramsey sedation level, then you can objectively look at what the score is and what the patient would be experiencing at that level of sedation. So for example, you may have a physician order to sedate the patient to a Ramsey of 3. So that means you would sedate them to the point that they could respond to commands only. If you have them at a sedation level of 6, that's deep sedation, to where the patient is not able to exhibit a response. So again, the Ramsey Sedation Scale is a way to objectively look at levels of sedation for patients who are ventilated. This is why drugs like Diprivan are great to use for sedation for vented patients, because Diprivan has or propofol is the other name for it, has a very short half-life. So you could cut the drip off and the patient could start waking up, and you could do a neurological assessment, or you could have them in deep sedation if you have a high dose that you're giving to the patient. But remember, whenever you're dealing with ventilated patients, you have to be careful not to over sedate them if they're on certain modes of mechanical ventilation. So for example, if the patient is on assist control, which is full ventilatory support, you could potentially have them deeply sedated because the ventilator is going to do all the work. However, if you have them on a mode of ventilation like pressure support mode, to where they have to participate in the work of breathing, then it's important that you do not over sedate them. Also, one of the things that you've got to consider is that when you're weaning a patient from the ventilator, it requires that the patient participate. And the patient is not going to be able to participate if they are over sedated. So that's another thing to think about. So that's why, again, it's really good to use drugs like propofol that have a short half-life when you're trying to wean patients. And there's another drug called Presadex. Presadex is a newer drug. Presadex is a drug that you can give to patients that will calm them down, but it will not over sedate them. It will not have as much CNS depression. So Presadex is a great drug to use to wean COPD patients off the ventilator. because one of the problems with weaning patients off the ventilator is not necessarily that they're not physically ready to be weaned from the ventilator and that their respiratory status isn't up to par, but a lot of times these patients get very anxious and they have anxiety attacks. And these anxiety attacks may indeed prevent you from being able to wean them from the vent. They start hyperventilating and moving about the bed and trying to pull at the tube, etc. So Presadex is a good drug to use for weaning as well. Also, you've got to think about other drugs that the patient is giving, such as the patient may be prescribed pain medication like opiates. You've got to be careful to not have too many opiates on board when you're trying to wean them off the vent as well. So the question becomes, when does weaning begin? So ideally, weaning parameters should start the very next day after a patient is intubated. And weaning parameters should be looked at from respiratory therapy standpoint, from the nursing standpoint on a daily basis. And these parameters would be communicated as well with the intensivist or the pulmonologist that is running the ventilator. And these parameters would give you a good idea of how much is the patient able to do on their own without support of the ventilator. Again, whenever you're trying to wean a patient, you do need the patient to participate in the process. And there's many different reasons why a patient may not be able to be weaned from the ventilator. It could be because of anxiety, like I mentioned. It could be because of delirium. And ICU delirium is a very, very common problem. And remember that delirium is different than anxiety. Delirium is the hallmark feature of delirium is that the patient is not able to pay attention. And so it's very difficult to wean someone off the vent when they can't pay attention to instructions. So again, remember that ICU delirium is treated differently than anxiety. If the patient is truly delirious, they need to be treated with antipsychotics. Whereas if the patient is anxious, they can be treated with other types of drugs, such as low doses of benzodiazepines. So you have to think about that as well. Another thing that you've got to think about when you're trying to wean a patient from the ventilator is their nutritional status. And this is why you want to get them enteral tube feeding as soon as possible, that started once they are mechanically ventilated, intubated and ventilated. And that's going to help with extubation and weaning as well. Another thing you've got to think about are things like fluid volume status. Sometimes if a patient is fluid volume overloaded, if you diurese them, it's going to make it easier to wean them from the ventilator. And a lot of this comes down to communication between the nurse and the physician and what's going on with the patient. Why is it they can't be weaned from the ventilator? And sometimes it may take multiple tries to start weaning a patient from the ventilator, especially if they come in with full-fledged respiratory failure, and especially if they have underlying COPD. Also, you need to assess how strong the patient is. Do they have enough strength to be able to breathe on their own without the aid of the ventilator? And one of the ways to tell whether or not the patient is strong enough is to have them lift their head off the pillow and try to touch their chin to their chest. And if the patient is able to do this, if they're able to lift their head off the pillow by themselves and basically touch their chin to their chest, then they're probably going to be strong enough to attempt weaning from the ventilator. So a lot of things come into play when it comes to weaning the patient off the ventilator. Their anxiety, their nutritional status, their fluid volume status, their hemodynamic status, um, and there's how strong they are. And it does help to have the patient trait if you're weaning patients. Sometimes it takes a patient to be trait before they can be weaned from the ventilator. And typically speaking, if a patient is intubated for longer than 14 days, then you need to start considering a trait for the patient, and the physician needs to consider this. A trait makes it easier to wean patients off the ventilator because it's easier to clear their airway via suction. It's easier to pop them on and off the ventilator. It's not easy to intubate and extubate patients. It is easy to pop people off and on the vent via the trach. So that may be necessary for some patients. But again, drugs that have short half-lives like Diprivan are good to use with ventilated patients because of the short half-life, because it's easy to increase or decrease their sedation level and to do the Ramsey scores. Drugs like Presadex makes it easy to wean the patients from the ventilator because this drug will relax the patient without sedating them. One of the cautions about Presadex is that Presadex may cause bradycardia and bradyarrhythmia with patients. Some patients are more prone to bradyarrhythmias than others. So drugs like Versed make it more difficult to wean the patients off the ventilators, because if a patient is on a Versed drip, especially older patients, the Versed and the effects of the Versed tend to linger. So if a patient is on a Versed drip, especially if it's an older patient who has compromised renal functioning, then the effects of the Versed tend to linger, and it makes it more difficult to wean them from the ventilator. But these are all things to consider. Whenever you have a patient who is ready to be extubated, you need to consider multiple types of evidence that they're ready to be weaned. What I mean by this, you're not only going to look and see how the patient is doing with your own eyes, but you're also going to be looking at ABG results. Are the ABG results with them doing most of the work of breathing consistent with ABG results that would be associated with someone who could breathe on their own? You would look at chest x-ray results. What does their chest x-ray look like? And again, you would look at bedside assessment with how they're doing in the weaning process. How are they doing as it relates to being able to have most of the work of breathing done themselves versus the ventilator. And it's a combination of things that are evaluated before it is determined whether or not a patient can be extubated. Now, if the patient does have orders for extubation, as the RN, you've got to be ready for this, okay? You need to have suction and a Yankauer suction catheter ready at the bedside. You need to have a towel that you can place over the patient's chest so that there's going to be a lot of secretions the patient may have. You're going to need to elevate the head of the bed. You're going to need to be able to have a nasal cannula or a venti mask or a non-rebreather mask ready, or whatever type of oxygen delivery system the patient is going to need once they are extubated. All of that needs to be ready. And you need to be able to coordinate this with the intensivist and the respiratory therapist. Also, before a patient is extubated, you need to make sure that you cut off any tube feeding, because If they're getting tube feeding, that's going to increase the risk of aspiration. When a patient is extubated, they are going to be kept in PO for a certain period of time after extubation. Now, when a patient is intubated with an endotracheal tube, oftentimes they lose their gag reflex because that endotracheal tube can dampen their gag reflex, and sometimes it may take 24 hours or more for the patient to regain their gag reflex. You want to make sure that you have the patient and keep them in PO after extubation until they can demonstrate that they can swallow appropriately. Sometimes these patients may need a speech and language pathology evaluation once they're extubated to determine whether or not they can take PO. And again, these patients are going to be on aspiration precautions. The last thing you want to happen is to extubate a patient and then have them aspirate and end up back on the ventilator. Sometimes patients do have to go back on the ventilator once they're extubated. Sometimes patients do fail, and they can fail for a variety of reasons. They can fail because of the fact that they just weren't physically ready. They can fail if they start getting fluid volume overloaded. They can fail if they aspirate. They can fail if they're not oxygenating the way that they should. So again, the Ramsey sedation scale is a sedation scale that you can use to look at their level of sedation more in an objective way. Again, the physician may order different levels of Ramsey sedation, and this helps you be able to be consistent with what the physician is ordering as it relates to sedation levels. Again, you would not want to oversedate patients, especially if you're trying to wean them from the ventilator, because they do have to participate in the weaning process. So I hope this information was helpful, and I will see all of you next week. Take care.